Hello, everyone, and welcome to today's webinar, Convergence in Health Creation, How Integrative Health Leaders Are Shaping and Can Shape the Medical Industry. My name is Tamara Moore with the Erris Group, a communications firm in DC. I will serve as today's moderator. Before we get started, I would like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer screen in the upper right corner. If you have joined the webinar by phone, please enter your PIN number, which can be found in the audio pane of your control panel. All attendees will be placed in listen-only mode. You will have the opportunity to ask questions during today's discussion. To ask a question, submit your text question through the Q&A section of your attendee control panel on your screen. We will collect all questions and address them during the Q&A session at the end of today's presentation. If you have a question or issue with your webinar technology, you may type your question through the Q&A section of the attendee control panel, and someone will respond to you as soon as possible. You may also contact GoToWebinar technical support by dialing 877-582-7011. Today's presentation is being recorded and will be posted to the Leadership Program website in the coming days. I'd now like to turn the call over to today's host, Dr. Adam Perlman, Program Director of the Leadership Program in Integrative Healthcare at Duke University. Adam?
Thanks, Tamara. And thank you all for joining us today. We actually have a great program for you. But before we get started, I just want to mention that the Leadership Program in Integrative Healthcare is now accepting applications for our 5th cohort, which will begin in February of 2019. And it's really never been a more exciting time to be in integrative health and medicine and in the field, and I'm really proud and excited by the work that many of our alumni are doing to advance the field. The program, if you're not familiar with it, offers extensive, really personalized leadership training. There's a guided curriculum that was developed by integrative health experts from around the world. There is mentorship from faculty from Duke's Fuqua School of Business on a business project that all of the participants complete. Again, it's a one-year program. It's really designed to make the most out of our participants' time with 3 in-person immersions at Duke throughout the year, but then complemented with really one-on-one mentoring calls and a really rich online curriculum. So applications are now being accepted, and they will be accepted until September 30th. If you're interested in applying, you can get more information about the program and access really a brief application at the website, which is listed here, which is www.integrativehealthleaders.org. Or if you have questions, you can always contact our program manager, Damien Galena, and again, his email at Duke is listed on the slide. Next slide, please. Great. So I'm really thrilled. Joined today by a good friend of mine, longtime friend and colleague of mine, and one of our leadership program faculty members who really has done a lot of truly amazing things to further integrative healthcare, John Weeks. And John Weeks is a writer, speaker, organizer, executive with really more than 3 decades of experience as a leader within the field of integrative health and medicine. Today, John will review the history of integrative health and sort of the effect integrative health leaders have had on the healthcare industry overall. So with that, I'd like to turn the presentation over to John. John?
John, you
Thank you very much. Okay, thank you very much. It's a pleasure to be back with all of you and have an opportunity to share a perspective on this work with which you and I, Adam, have been engaged for a couple of decades, but I'm going to be taking it back to about 50 years ago for my perspectives here. So the brief overview is I'm going to look first at a perspective on the way the field has moved forward, and then focusing along the way on the forms that leadership took. Then step back and review briefly some of that history, what I'm calling the shadow history of the dominant trajectory of medicine that has created a context which I see and will present as an opportunity and a clear direction towards convergence in our worlds. And along the way, I will be laying out the roles of leaders and prospective roles, and you will notice a trajectory that's about an ascent of work in groups and ever greater collaborations. I mentioned, I'm going back here again because one must in this world honor those with whom one has quietly partnered, and for much of my work, have had philanthropic partners presently. Ruth Westreich and Southern California University of Health Sciences fund a lot of my work. And of course, there's the silent partner frequently of one's spouse who's a main part of my work continuously. So we'll head towards convergence. Why history? I don't know how many of you are history buffs, care much about it, think we even have much of a history. I know a lot of you probably have moved into this field in the last year or two. Why is it important? This Walter Benjamin quote, I like very much, and I think its application here is that when we begin to tell our own history, the way we tell it, the way we view it, actually becomes who we are. And to the extent we see ourselves, I would say, as victors, we can help shape a view of ourselves and a future for ourselves as such. And I think this who I'm presenting here kind of fits along those lines. Of course, the other main reason to engage study of history is to see what's been done, to see where you can learn, and hopefully not thoroughly go back into the ruts of the past, but hopefully move things forward. For you who care more about this, the links that are there below are for a longer version of the history than I will be giving up front here. So I call it Cliff Notes because I moved through it pretty rapidly. Going back 50 years to what I've come to view as a sort of cultural amniotic stew that is by the conventional field often referred to as a counterculture, what I would suggest we should re-own as an affirmative culture that's affirming different sets of values that happen to be framed in alternative ways, but actually we're seen as alternatives, but we're actually affirming different kinds of things, such as social justice, the role from Adele Davis of food in our health, which was denied back in the 60s, the need for the ascent of the female in our culture at a time when I don't need to remind any of us here, there wasn't much respect. Rachel Carson's incredible work in teaching us about the whole system that we live in through Silent Spring and her other, some of her other writing. You know, what happened in what was most directly the countercultural movement, the reconnection to the land, the felt need to at the time that Dustin Hoffman was being urged to go into sticks, which of course is a field that has grown in the last 50 years. These were, you know, affirmative steps towards new directions. And what happened is those ideas came out into the culture, and some people said, well, how do we move them? How do we make sure they don't just pass by? How do we make sure they're not just things that happen on an acid trip or where you're high some night, but are ideas that we think are value enough to figure out how to embed. As a chronicler of the field, I began to realize this fascinating thing that in the 78, 79 era, there was suddenly birthing of many different separate entities in order to move different ideas forward. I was at part of, I began a little bit later, what's up at sort of 1 o'clock on the dial is the AANMC, which is the naturopathic medical movement. I started actually in 83, but it was 78 was a big date to me because I was at John Bastyr College. It was founded that date. There was another naturopathic college founded that date, and there hadn't been one for 23 years. So it already was, so why is 78? When I started working with others, I realized the Holistic Medical Association, the Holistic Nurses Association, around that time, the modern herbal products movement, the wellness movement, the patient-centered care movement, all of these things came at the same time. And we began this era of what I say in silos. They were professional creation. The holistic docs were trying to figure out ways to first convene, to connect with each other, realize you weren't alone, to have conferences, begin to journal, began some work about defending the rights to practice, whereas people like in massage and acupuncture and naturopathy, those fields, the work was focused on professional formation, licensing, setting up your accrediting bodies, things like that. Those were the directions of leadership inside, typically, of these individual silos in this second phase, which I put through to the early 90s. Interestingly enough, in the same time, we began to see some research underpinnings also popping up. Pelletier wasn't so much doing the research, but capturing it in a book that continued to sell and sell and sell. But there's Benson, John Kabat-Zinn at the same time, roughly bringing forward what has become obviously a research direction that has underpinned all of our work to connect the mind and the body, to get more appreciation for the mind and body relationship in health and medicine. And there we were in roughly that same time frame. So there's research that was going on also in its silo. The change maker that created the integrative term was, interestingly enough, the consumer. And it was a survey of consumer behavior that actually captured the fact that people were doing some of this work, writing books like Ken's book, were licensing, so people had more access to massage, to acupuncture, to different practices. The holistic doctors were writing books, going on tours, talking up some of these ideas about a different way. That's helped to stimulate the growth of the popular movement, which was then captured by David Eisenberg and his group out of Harvard. It helped that it was out of Harvard and in the New England Journal of Medicine, which put a nice seal on this being real, that there was so much, basically what had previously been invisible activity going on. And what I'd like you to be thinking about is the whole of our public healthcare related medical and healthcare decision making, that there was this entire body of it that was basically invisible and scorned until this study came forward. At the moment the study came forward, suddenly one of the main things that happened is that people who were intrigued, connected to, had some piece of this and wanted to move it forward, whether it was in academic medicine or in their employee benefit package or in their hospitals, were now powered up to say, look, at a third of adults are using this stuff already. It's time that we begin to engage. There was incredible empowerment that happened in the process, and that opened the next phase, which I refer to as the era of non-integrated integration. So what had happened was the finding of the consumer interest actually coincided with a time in regular medicine hospitals were beginning to think about, marketing more directly to consumers. Pharma was more. The potential to advertise, there was a taboo against that in the past. That was being broken. And so suddenly there were all these consumers, but there wasn't really any buy-in at all at the level of the medical direction. And so the question was, how do you do these things, respond without actually having to significantly value whether or not what these practitioners and these consumers were doing could be worthwhile overall to creating optimal health care. And so the models that were set up were these non-integrated models of a clinic that was off to the side, that often was not even in the hospital. It was out in the community someplace with very little interrelationship often, and frequently a very tense relationship with the parent. I mean, there might be people inside who sponsored it, who liked it, but when it came to respect inside of the culture of the medical doctors there, very little typically. And then on the payment side, what you saw with the development of carve-outs, what they're called in the industry, where you pay a little extra money for a little extra benefit. You're not thinking, well, if we use more of these folks, then we actually diminish the price of healthcare over time. But during this time, there was, a lot of work that continued, and particularly with the time that in this era when the research infrastructure began to develop inside of the federal government through the Office of Alternative Medicine, then what became the National Center for Complementary and Alternative Medicine, now is the National Center for Complementary and Integrative Health, and began to do research to develop some of the research infrastructure that clearly is informing a lot of the activity in the era of convergence that's coming forward. We also saw in that time the formation of some of the first programs in academic medicine. Another found piece of our history was this wonderful coincidence of significant collaborations all developing at roughly the same moment in 2001, 2002, 2003. And my sense on that is that the opportunity that was created by the force of the consumer movement and the number of practitioners out there showing that, part of what's going on in healthcare is these alternative natural health approaches. Those who were inside of it began to think, how can we have the most influence, again, in order to move these items? In many respects, it was the same kind of thinking as back in the 70s when people were forming individual professional groups, but now it was saying to move what we want to do, we'll be better off if we band together. In fact, the licensed complementary and alternative health people got a very clear message from U.S. Senator Tom Harkin in the late 90s that led people like Pamela Snyder and Sheila Quinn to help really drive some of the formation of the Integrative Health Policy Consortium, when Harkin said, if you all want to have any value in our dialogue here, you really ought to kind of get together and figure out what your shared message is. Because if you all come in one by one, it's going to be hard for us. You're not going to get anywhere. It was a message that many of us took to heart. And so these collaborations began. One of them was, down at like 4 o'clock on the slide here, is there were philanthropists who had been involved, who in individual hospitals, health systems, and they began to think, maybe we can power ourselves up more if we combine our forces and set our direction. And they did some wonderful things in the roughly 15 years that the Brave Well existed. In 2009, they brought integrative medicine to the Institute of Medicine and the Summit on Integrative Medicine and the Health of the Public. They brought a show onto PBS TV. They were major funders of one of the other. I'm calling it's a sort of single discipline focus, but the collaboration that is the academic consortium for integrative medicine and health that Duke is part of. And now there are roughly 70 med schools and affiliated teaching institutions. It formed again by these people who had started individual programs in their med schools and said, you know what, in order to move this, in order to support each other, let's form this group. And as I will share a little later, in the present era of more opportunity of convergence, there's been some sort of wonderful policy work that the consortium has begun to do. The Integrative Health Policy Consortium really grew directly out of what Senator Harkin had called us to do. Chiropractors, acupuncturists, naturopathic doctors, massage therapists, and now it's expanded to 27 partners in health. They're at IHPC.org. Go take a look. They're a very broad consortium, played significant roles in a couple of key pieces of languages in the Affordable Care Act of 2010. Integrative medicine, well, actually integrative health appeared for the first time in federal statute there. Some of the other licensed complementary alternative medicine practices besides chiropractic had their first appearance in federal statute outside of the NCAM legislation, partly through IHPC's work in the Affordable Care Act. Their website has a long list of their accomplishment. There was this academic collaborative for integrative health was set up really as a project of IHPC, but at that point carrying a mission that was broader than this, but to specifically be in dialogue with colleagues inside the consortium. It's one of the places where Adam and I had a chance to get to know each other and go for one of our first jogs together. More recently, I would particularly want to that an association has been formed for the first time, is from its definition interprofessional in the Academy of Integrative Health and Medicine, and then a organization that most all of us in different ways have a relationship to and are kind of pulling for and with, is the Integrative Medicine for the Underserved, which meets in DC next week if any of you can make it. So these were all in their ways significant collaborations that have some really fine track records. The longer versions of this presentation lay out some of the details. There we go. So let me just make sure, okay. So in this period of time, I would say there were two very significant lessons to us, and I could include myself at the top of this list. We're relatively naive to things worked. One of them was the idea that many of us thought that, well, what we're doing is going to save money. It costs less. This is just belief. It costs less, and we deal with some of the causes of chronic conditions if we can keep people from needing downstream services, major surgeries, etc. Bring them onto a path to health. We can save the system a lot of money. What we didn't get is this rule I'm going to share with you here, and I urge you to just embed it deeply into your own minds, which is that an health insurance company is a financial institution that fundamentally benefits over time when your premium costs go up, as you see in that chart below. There's an acceptance out there that they can hold 20% of premium costs for administration, for marketing, for profit. Inside any given premium year, they want to keep costs down, but overall they realize they can just move, as you move prices up, they have a lot more money to play with, as the chart shows. So they're actually not your ally in reducing costs. It's not what an insurer wants. Harsh judgment, but real. The second, and this is even harder because we're getting to the practitioner side, and it's easy for a lot of us to point fingers at pharma and at insurance. It's less easy to point towards, assembled groups of practitioners and the institutions that house them. But in the fee-for-service environment, basically everybody is driven to do more. And we've ended up in a situation where at least a third and perhaps 50% of what we do is unnecessary. And we haven't done a very good job at slowing that with various initiatives to do so. And it's partly because the hospital's bottom line has to do with how many angioplasties, how many knee surgeries, how many different procedures they're doing. And so you have an incentive structure that actually is against health. It's in favor of managing the diseases through these procedures. But if you walk through the door with a program that says, I can keep your people from needing to use those services, you don't often get a warm welcome. I've been there. Many people in the field have been in those rooms. This isn't to say that there aren't friends who are aligned with those values. We'll get there. There's a whole portion of medicine that's trying to change us in a new direction. But these are two tough lessons that we learned when we came in kind of naively believing that we had some clear alignment of interest. The convergent era truly has to do with the movement from volume, the fee-for-service world, towards value, towards accountable care, towards expressions like patient-centered medical homes that we've seen, particularly since Obamacare. Before that, we saw it in the HMO movement, the real staff model HMO movement. And this is where the convergent becomes possible, where it was not so possible, and it is not so possible in the fee-for-service environment or in the volume-focused environment. Before going into the details of what those kind of bridge points are for connecting and where leaders have found ways to connect, I'm just going to back up a bit with a couple of slides about this kind of shadow history of this period of time where through 2000 roughly, it was just commonplace even after that to be saying we have the best form of medicine. The U.S. has the best form of medicine. And in many areas we continue to. Those who know me will know that I am a beneficiary of some of the most exotic products of the medical industry. And so there's no way that this is meant to be a criticism of what's been produced in that way, and that's the tension of our work. But in the midst of it, there is this shadow history, which is that we began to realize not long after Medicare and Medicaid were passed that we were beginning to have a cost problem as insurance was creating the ability to generate more money in medicine. And so shortly after that, there's the first HMO Act. There was a realization that we needed to break out of this top-down thinking and move into team care with an early look already at how do we implant team care. That report unfortunately gathered dust. We began to see in family medicine in particular the concept of the biopsychosocial, now enviro model of primary care that begins to look in much of its frame a lot like kinds of things that you see in holism. And a study that many of us kind of found because, emerging into the integration dialogue, you get hammered by where's your research, where's your research? And the Office of Technology Assessment that noted up front that that at that time there was a conventionally formed procedures, only 10 to 20% had some sort of quality evidence. So it was sort of a childhood playground, you're going to call me that, we can say the same. To you, it was useful data, but it also was an awareness that moved things towards evidence-based medicine. It's been one of the terrific ironies of the whole dialogue that the question of evidence is always what's in the face of the integrative community, when at the same time medicine itself is trying to actually begin to more routinely focus on how to structure care in appropriate ways around evidence. Again, major cost issues expressed themselves in the Clinton reform. Cost issues expressed themselves with employers basically saying we need to take this into our own hand. Healthcare is too important to leave it to the doctors. And this rumbling internally that obviously surfaced with the Clinton reform in a big way really hit big time with this study in 1999 to Erris human. And, you know, the finding that there were 100,000 deaths associated with the regular practice of medicine. Then people like Don Berwick saying, we are not going to let this go to sleep. Dust is not going to gather on this volume. And they started the 100,000 Lives campaign out of Institute for Healthcare Improvement. It was a gutsy thing to do in the face of, imagine, you know, to turn to your friends and say, going to wear our errors on our sleeves. We're going to go out and start a campaign to address them. You know, and sadly, it's 15 years later, and the McCary study out of Hopkins came up with an assessment that the number is actually even higher today. But it created the context of Crossing the Quality Chasm, which came out in 2001, that really began to underscore this movement from volume to value and the value-based medicine movement. And this is what creates, I believe, this era of convergence for us. And it shows up in multiple ways. The efforts to shift payment incentives in the Affordable Care Act, the movement itself for patient-centered care, the triple aim that's now the quadruple aim, when we realized that we needed to be thinking about you know, clinician satisfaction as well as patient satisfaction. You know, you look at those and you go, well, a lot of people who move into integrative care and these practices actually do it to have more satisfaction. We might have something to teach over there. More satisfied patients, that's always been a watermark for the integrative, for the complementary, the licensed integrative fields. Most of the modeling that in the kind of rich era of early exploration in the late 90s, the dialogue around how do we form these new teams, big part, heart and center of the work we've been engaged. And of course, so when the interprofessionalism movement began, it's got patient-centered concept at the center, then it's a great place to connect with from our value set. You know, the personalized medicine kind of goes in its own ways with, but it affirms the fundamental of idea of individuality, which has been carried forward in the integrative model and integrative principles along the way. So, you know, again, just context. The people at the front end of this is at the Global Forum, are talking about a need for a big change, a transformational change, says Malcolm Cox. And his partner who was running the Global Forum and the National Academy said it's time to break some boxes, not just tinker around the edges. And this other that is old hat for all of us, because we've seen ourselves as parts of an effort to shift thinking towards health away from just suppression of symptoms and or disease. We began to see, after the Affordable Care Act, in the dialogues, in the sort of heady days of trying to figure out what it was, these people grappling with new language. And this is just one of them, a former AHA president, saying not only do we need to move from sick care to health care, but he says, and I'm not sure that any of us fully understands or knows the recipe. What I would like to put to all of you, and what I'll be reviewing next, is actually what parts of that recipe, may rest with the experience, the approach, the philosophies, the practices that our community might bring. So, the era of convergence. I'm just going to pop through some examples of leadership in this time, when now we have the opportunity for alignment with these changing incentives and these values. I alluded to this before, the academic consortium, the Consortium for Integrative Medicine and Health, for a time was relatively quiet in the policy arena, and finally I think it woke up via Arya Nielsen, an acupuncturist who was working at one of their centers, and a researcher who partnered with Ben Kligler, who was there. And then the consortium got involved, and they asked the Joint Commission to rethink their pain guidelines. It was a first, I think, real movement into significant policy to great effect. They very clearly listed a number of non-pharmacologic strategies, as you see at the bottom: acupuncture, chiropractic, osteopathy, manipulative treatment, massage therapy, PT, relaxation therapy, CBT, and they didn't end it there, but that was the, consider these. And they called out also for more concern with using pharma. So we began, through these leaders, to have some more say in positioning our culture now towards embracing more non-pharma approaches. The consortium with others, these three other key teams, actually got together and collaboratively produced this little pocket resource meant for practitioners called Moving Beyond Medications, realizing, via multiple ways we need to be changing people's practices. And among those ways are to give them handy little tools in their hands to think about what might be useful and when. And this Moving Beyond Medications was a product that was produced and through this consortium, again, to give it more clout going forward. This isn't the John Weeks piece. This isn't the consortium's piece alone. This is something that has a level of agreement across all of these entities. Meantime, at the state level, and principally driven by the license, in this case acupuncturists, but similar things by practitioners of other sorts, have been efforts to create pilot projects and or just change laws that will create more access, many of which are framed around what the Academy of Integrative Pain Management likes to reframe the opioid crisis as the crisis in chronic pain management, which I urge you all to start thinking about. Calling it an opioid crisis is to accept and adopt reductive language. It's useful in certain environments, but that's not what the crisis is. The crisis is that we're not thinking right about how to work with chronic pain. And that's what we need to be addressing. But at any rate, these leaders have all been stepping up, going to their friends and saying, let's work pilots. Or in the case more recently in Maine, a group went in and got a mandate passed that requires coverage of naturopathic physicians in the state of Maine. And that's the kinds of leadership activity at the state level that are supporting some of this transition. This is all being done, the integrative pain work, in the context of, credit the research going back to 77, but through the NCCIH at the National Institutes of Health and other agencies, we're now seeing integrative strategies embedded in multiple publications and guidelines that can help change practice. The convergence is happening in the guidelines that are meant to share best practices to clinicians. We all recognize that this pain issue in the U.S., our strange reality that we use 95% of the world's opioids, is an opportunity for us to move in the dialogue. And as a matter of fact, many of the people who began to choose alternative providers in the 80s, acupuncturists, massage, chiropractors, yoga for that matter back then, and for gut issues, naturopathic doctors were in pain. And so it is pain that has driven a lot of the use of the non-conventional strategies. So now it's this moment to pull it together. The Academy of Integrative Pain Management pulled together a couple of other organizations, Balanced Pain Management, IHPC, to host a summit last year, which drew CMS, Aetna, Blue Cross, some of the people who really can make decisions about the access people have to complete the convergence and transition the way that people are prioritizing choices in pain management. Whatever any of us think about what's going on in Washington, D.C. now, and this initiative the people involved will testify that the mess that exists back there makes this work hard. But still, to make the changes we need, we need eventually to be changing some federal laws. To change federal laws, we've got to create context. We've got to create supporters. And a classic method to do that in Congress is to aggregate supporters around a caucus. And through some work with two members of Congress from Colorado, and truly led by the Integrative Health Policy Consortium, we now have an Integrative Health and Wellness Caucus that was kicked off at a briefing. When the slides come out, you can go to that site there. You can Google it up. It's all of the briefing sessions are actually available for you. So the leadership is, we've come together. We're having, through the Academy of Integrative Pain Management, a chance to meet in summit form annually. This is giving us an access to how to move things into Congress. But what I would really like you all, I was on a call shortly before this morning, and with somebody who was dissatisfied with the nature, the status of integration. And I go to these two brief stories and thinking about it. On the left side here is Don Berwick, who I've referenced, who I view as sort of the front edge of good medicine in the dominant school, in the value-based medicine world, and thinking about creating health. In 2013, he gave a talk at the IHI meeting where he talked about a 30-year transition of what hospitals should be doing in health systems in the U.S. And he introduced the idea of salutogenesis, of creating health as a focus. And in the context of his talk, he referenced his mentors. And his mentors were all people who basically are very close to and or deeply embedded in the integrative health and medicine movement. And referenced above all Wayne Jonas, who's at the sort of 3 o'clock position there of that trio. It's Dean Ornish below him there. And he said, you know, Wayne above all has mentored me into this. So there we are, our ideas, philosophies, practices, mentoring a guy who's at the front end of conventional medicine, trying to mentor them into transition. It's a worthwhile thing to just note that this isn't great man theory, Wayne, and they all grew out of context, right? And so this is an expression of all of our work. On the other side, you know, Tracy Gaudet, who's paired with Ben Kliegler, ran integrative medicine programs at the University of Arizona and then Duke for, I think, 13 years total. She when she talks about what she is doing now that she is directing the Office of Patient-Centered Care and Health System Transformation, she references what we developed, the whole person thinking that we developed in the integrative community. And of course, now they have a whole integrative health coordinating council that Ben Kliegler is running, and they're spreading this throughout the VA. The leadership is happening. I'm going to briefly go through these so we'll have a little chance for questions. So going forward, I love this quote from Rick Hecht, the new consortium leader, who's basically saying that success for us will depend on pulling together rather than working individually. And he's talking organization to organization. So I'm hoping, Rick just came in as chair, and hoping that we will be seeing even more of that out at that level. Look at who we are. You know, this is just really looking at these groups, and that is a subset of who we're connected to. But if we can think about beginning to mobilize and connect the social movement, you know, there's a connection to 600,000 licensed practitioners, tens of millions of patients, dozens of policy champions, scores, I would say, of potential philanthropic partners. You know, just inside of IHPC, there are these 27 organizations that are linked to huge communities each. You know, if we can come to collaborative decisions about core focal areas and stick to them and work with them, there's just tremendous grassroots power here. As we move forward, we need to be thinking about our next phase allies who truly work ourselves more closely to see where the benefits are and moving shared agendas together. Is it community health centers, employers, primary care docs, environmental groups? You know, some of this is not at all far-fetched. The National Association of Attorney Generals this last year showed up as a powerful advocate for us and actually has told insurers that watch out, we want you to do this. You need to be moving towards using non-pharmacologic approaches going forward. You know, this is sort of a pause for a prayer, but you know, to move these agendas, we're going to need to find some philanthropic partners who truly have the policy bug, who want to change, you know, the way policy drives medicine in the U.S. and realize that we have the infrastructure to truly make some huge differences. We're part of a global movement. It's not just here, it's globally. The WHO has just announced for integrative as long as traditional medicine. Here in our own hemisphere, the Pan American Health Organization has a very active effort networking nations. Very similar issues, trying to figure out the best uses of these therapies, practices, and practitioners in advancing optimal health. I invite you to inspirit yourself globally, act locally. One thing that we can each do is watch our language. I've been trying to learn how to do this myself, and that is Don't call something healthcare if it's not healthcare. Call it a medical delivery organization if that's what it's doing. Call it depression if that's what it's doing. And there are times when that's the right thing. Call it disease management if that's what it's doing. And there are frequently times that's the right thing to do. When it's healthcare, when it's fully healthcare, then call it healthcare. That's part of the way that we're going to be able to actually turn this thing, is to be able to call it by the right words. Our work in our fields, I would say, is part of a movement that has been identified in this Lancet publication from 2010, which was interesting for you historians. It was 100 years post-Flexner that this was published. And it was urging us towards a new form of education for health professionals, and that type of learning, instead of just informing you about this and that and this and that, then actually it's a transformative form of education that inculcates leadership attributes in order that we each can be change agents. And so this is the convergence. We are converging into an environment where the best minds and thinkers and planners in the dominant school of medicine are increasingly converging with us in alignment. Thank you very much.
Thank you, John. We have a few questions in the queue, but as a reminder, we do have a few minutes for questions. Submit your text questions to the Q&A section of your attendee control panel on your screen. Our first question is, how will the shift to value-based care benefit integrative health and medicine?
So, as I tried to share in the presentation, one example of value-based care is to think about teams and interprofessionalism. At the moment you do that, you really open yourself to say, well, should a chiropractor, should an acupuncturist, should a massage therapist, etc., be on that team? You're creating a context. So when you move towards a payment structure in value-based medicine that's not about production, you then are potentially open to ideas that say, well, if we do this, we actually can save from the need to do other procedures down the road. You have an incentive to save. And to the extent integrative health and medicine can save in the way that Patricia Herman, the RAND Corporation, has shown through her systematic review that we can, there are ways to dovetail there as well. I think that you start looking at experience and practitioner experience along a broad array of the values in value-based medicine. I think we hit pretty strongly in the integrative fields, and hope this is close enough to some sort of an answer to your question.
Great. Our next question, what is the data being used to drive implementation of integrative models? What's been most persuasive? Is it cost, outcomes?
The relationship to data of the whole movement is fascinating. I'm having a chance to speak on it somewhere else in September. There's no doubt that the body of work that the NCCIH has helped us develop around my body in particular, and acupuncture to a lesser extent, and some chiropractic and massage as well, is quite useful. People are carrying these documents around into meetings, showing the evidence base. So the basic evidence base is quite good. When you want to get somebody to actually cover you, include you, they tend to start asking, what's your impact on cost? How's that going to influence our whole cost structure? So if you can't actually show value, show where you sit around cost, the entrance can be troubled. So I think that's the basic answer. My own view is I've worked inside of insurers in the late 90s, and I did quite a bit of work with insurers and then with some hospitals. And not at 30,000 feet, but sort of at 6,000 or 7,000 feet maybe. There was the internal decision making often is around a kind of decision research and quality research that is also all around outcomes, and it's a much more rudimentary kind of evidence. But I think more often decisions are made with that kind of internally culled evidence that is often are made by published research on the outside.
And we have time for just one more question. Adam and Damien, this one is on the program. So who is right for the program? And they're wondering, is it mostly physicians or administrators?
I'm happy to take that one, this is Adam. It really is both, and it goes beyond physicians when we're talking about clinicians as well. I mean, one of the strengths, I believe, of the program is that we do have such a sort of heterogeneous group of individuals with different backgrounds, and people bring their perspectives. So, typically less than half of our cohort are physicians. We've had a number of sort of administrators, including chief financial officers for health systems. We've had clinicians from all different backgrounds, from nursing to allied health to sort of integrative medicine or health providers. And we've had health medical consultants. We had the head of HR from a bank who was really interested in bringing sort of the principles of integrative health to sort of the employee wellness and what they were doing there. So it really is, like I said, a very diverse group. And again, I think that really adds to the richness of the experience that we all have.
Adam, I could share. Going to say, as somebody who's been there a couple of times, the diversity is remarkable, and the diversity is rich. Is all I would say to whoever asked that. It's a really fascinating mix of mission-driven, smart people with lots of different types of questions.
Great. Thanks, John.
And then, Adam, did you want to deliver some final remarks as we close out today's webinar?
Sure. Well, of course, John, I want to thank you for a great presentation. I really love the way you walked us through that history, and you yourself are just a great example of a transformational leader within integrative health who's had a really dramatic impact over the last 30 years. So thank you. Obviously, I want to thank all of you that joined us today for the presentation. I want to encourage you to go to the Leadership Program website. Again, it's www.integrativehealthleaders. It's up there on .org. You can see it up there on your slides to access a recording, though, of today's webinar if you'd like, or check out other resources that we have available. There is several white papers that we've written about integrative health and leadership and some of the principles, and there's information about some of the great work that our alumni are doing. There is recent newsletter articles that are written by faculty and other leaders in the field. You can sign up to get that newsletter. It's, I think, pretty much quarterly. So, but with some very interesting articles, if this is a topic, as it must be, because you're on the webinar, that interests you. And of course, you can feel free to contact Damien. His email is up there as well, our program manager, with any questions you may have. And I hope and to look forward to meeting some of you in future cohorts. So. Thanks for your time, and I think this concludes our webinar and our presentation.